My name is Aruna Arora. I'm the president of the Medical Association, and today we have three guests. We have Dr. Harris, our state health officer, and we have Dr. Don Williamson, who's president of the Alabama Hospital Association, and we have Dr. Bill Admire, who is the chief medical officer of Mobile Infirmary. And I'm going to start by, Scott, do you want to give us an update?
Sure. Thank you very much, Dr. Aurora. It's good to be with you guys again. I just want to remind you, we've been doing these talks on Thursday afternoons now for a few weeks. We'll be back next Thursday afternoon also to live stream this at 4 o'clock. So please come back and join us. It's a great opportunity for us and the Medical Association to bring you people who really are on the front lines and are seeing what's going on in our state. So it's good to have you with us. And I want to take just a minute to give you a quick update before we get to our guests. I think most of you viewing this are probably aware that we're in a pretty difficult situation right now in Alabama. We're seeing case numbers that are increasing at a rate that we really haven't seen before. We've not quite reached the all-time highs that we had in our state back in December and January, but we're going to be there in the next few days. Things are unfortunately very difficult for us. We've seen over the past couple of days over 4,000 new COVID cases reported to us each day. We've not had that in many months. I know our team here is going to talk to you about the situation in hospitals, but our hospital situation is really accelerating at a pace that we've not seen before, which is going to make it very difficult for our state. We are unfortunately beginning to see deaths now at a rate that frankly, we kind of expect, given the case numbers that we've had. You know, the numbers of deaths we've seen have been in the double digits now for about the past 8 or 9 days. We had not had any days with double digit numbers of deaths for several months. And now we're seeing that. Deaths, as you know, always are what we think of as a lagging indicator. The deaths show up later after we see other things. So when you see this number of deaths going on, that's a clue of how many people were getting infected 3 or 4 weeks ago. Because that's about how long it takes for those numbers to show up for us. So we have had a problem now for a few weeks, and it appears, unfortunately, we're going to have a problem for a few more. I just want to remind people that vaccinations are picking up. Thankfully, if you have not decided yet to be vaccinated, please talk to your own doctor and let that person help you make a decision about what's right for you. We have had about 3 to 4 times the number of people getting vaccinated each day over the past 3 weeks, as we had been seeing really in all the month of June and into the month of July. So vaccination numbers have picked up quite a bit. But, you know, with most of these vaccine products, you need 2 shots that are going to be 3 or 4 weeks apart. You really need a couple of weeks after that to really develop full immunity to make sure you're protected. And so we want you to get vaccinated as quickly as possible. And yet the real full benefits of those vaccinations are going to be sometime in late September or approaching October, because it just takes a while. So please don't delay. Please consider getting vaccinated as soon as possible. We've got vaccines available in over 1,400 places around the state. You can go in any county in the state of Alabama today, multiple locations without an appointment. You get a vaccine that's totally free. You can go to vaccines.gov, that's vaccines.gov, and find exactly the location of all the places where vaccinations are being given. You can even search by a particular product if there's one brand you prefer over another. So I'll finally just mention Dr. Aurora. Last week, we had a great visit talking about fertility and talking about pregnancy and some of these other issues. CDC came out with new guidance this week that just strongly strengthens their recommendations for pregnant women to get vaccinated. We do know that women who are pregnant are somewhat, in a way, immunosuppressed, if you will, not in the traditional sense, but they are more likely to have serious disease if they would happen to get infected. That's bad for the mom and that's bad for the baby. So CDC has looked at tons of safety data. We have thousands of people now who've been vaccinated and have become pregnant or were vaccinated while they were pregnant. There are no safety problems at all identified with any of the vaccine products. And we strongly recommend that all pregnant women get vaccinated against COVID-19 because it certainly prevents them, in most cases, from getting infected. So that's just all the update I had, Dr. Aurora. Let me turn it back to you.
Okay, yeah, Dr. Harris. So in the meantime, as people are revving up and getting vaccinations, can we discuss masks during this surge that we are currently in?
Sure, that's a great idea. Masks have really unfortunately become this partisan issue in America. I don't know how we got to this point, but masks shouldn't be that way. COVID doesn't care if you're red or blue or who you voted for or if you didn't vote at all. Masks, on the other hand, protect you no matter who you are. There's certainly, again, lots of debate about it, but there's no debate among the scientists who look at how this disease gets transmitted. Masks are an effective way to protect you from other people, but also to protect you from spreading disease to people if you yourself are infected. With the strain that's circulating in Alabama now, which is mostly 4 out of 5 times the Delta variant, people can become infected with Delta, maybe not feel all that sick, particularly if they've been vaccinated before, and yet they're capable of very easily spreading the virus to other people. And so that's why masks are so important. They do afford you some protection, but they also protect the people around you. They protect the people that you care about. They protect the people that you work with or live at home with or go to church with, because you can spread the disease and not even realize it. So we strongly recommend and stand behind the recommendation for universal masking in our schools, K through 12 schools. We also recommend that adults who are going into public spaces indoors also mask up, whether you're vaccinated or not. That's the very best advice we can give to keep you and your family healthy.
Well, that's really helpful as we are shocked to see that we have reached numbers close to the highest that we've ever been in our state January of last year. So thank you. Well, it's a really important message that y'all need to hear from the hospitals, because the hospitals currently are in situations where COVID care is affected, but so is non-COVID care. So Dr. Williamson, if you can start off giving us some general overview of our state, and then we'll let Dr. Admire describe what their community is obviously being very much hit, and he can describe what's happening in the Mobile area.
Well, thank you. You're right. Hospitals are in the midst of what is the most rapid expansion of COVID that we've seen since the pandemic began. As Dr. Harris pointed out, we had over 4,000 cases today. And in fact, our 7-day average cases have gone up by 25% in the last week. And so as we look forward to what it's going to be over the next week to 2 weeks, we're not seeing anything that's going to slow this down. If you look at our positivity rate of the people who are getting tested, 24.1% of them are positive. The ideal number is less than 5%, and we got down to 3% or something near that back in June, which seems now like a lifetime ago. Again, around the 1st of July, we had about 200 people in the hospital. Today, we had 2,441 people in the hospital. Our 7-day average in hospitalization is increasing by 37% in a single week. On the path we're on right now, adding the cases we're adding, by next week, probably by the middle to end of next week, we will exceed the 3,088 cases we had in January of earlier this year. The problem when hospitals get full because of COVID is not just COVID. It impacts everything. Now, so let me just give you an example. Today in Alabama, in all of the hospitals of Alabama, we only had 5% of available ICU beds, only 73 ICU beds across the state of Alabama. And in some places, there were no ICU beds. There were no ICU beds available in Montgomery, none in Baldwin County, none in Dothan. There were theoretically 10 beds available in Mobile, but there were hospitals holding patients, more patients who needed acute medical care than there were ICU beds. So basically, throughout the state, we're now in situations where we're seeing patients who show up in the ER needing to be admitted, spending, in some cases, days in the ER getting ICU level care in the ER because there's no place for them to go upstairs. What does that translate to? Well, what that translates to is, yes, that is a problem for the patient with COVID, but it is a bigger problem for the community at large. mean, unfortunately, we're still having strokes, heart attacks, motor vehicle accidents. Kids are still falling out of trees. And in many places in Alabama today, we cannot guarantee you that if there is a mass disaster in that community, that we can find beds to take care of all of those patients in that community. We've already had hospitals have to divert patients to Georgia to get care. We've had hospitals have to divert transfers and send patients to other hospitals. The situation is exacerbating rapidly, and unfortunately, it's not going to just exacerbate for COVID patients. It is going to get very bad for everybody, for every sort of condition. We have hospitals that have already eliminated non-urgent procedures, and I use that term rather than elective procedures because these aren't plastic surgery. These are hip replacements that are important for patients to be mobile, knee replacements. I'm hearing stories of patients who may have had cancer surgery scheduled that didn't have to be done immediately, but they're being delayed as well. So one of the consequences of this is we see people after the last surge, we saw people come in with more advanced disease than they would have done otherwise. So COVID is a critical problem in our hospitals. It's getting worse, and it's almost certainly we're going to exceed the levels of January, and the system almost failed to be able to respond in January. And we are now faced not only with this problem of being overwhelmed with people, we have our staffing situations are much more tenuous than they were in January. So it's going to be even more challenging for us to take care of 3,000 patients now than it was in January. Just as evidence of this, we now have the greatest number of pediatric patients in the hospital with COVID that we've had since the beginning of the pandemic, 43. Now, that may not sound like a lot, but we have pediatric patients who are in the ICU. We've got pediatric patients on ventilators. And remember, school is just starting. These are all things that are going to get worse. So I just would even follow up on the comments that Dr. Harris made. Vaccinations are critically important for September. They are our solution out of this, but they're not going to alter the course of the pandemic for the next 3 to 4 weeks. We are set on a path that looks disastrous. There are only a couple of things that we can hope for. One, people will wear masks. That will clearly reduce transmission. And secondly, the use of monoclonal antibodies, drugs that will keep you out of the hospital. And they work in two situations. They work in individuals who have been exposed to someone who has COVID. If you've been exposed to a family member that you have close contact with and they have COVID, talk to your doctor. See if you're a candidate to get drugs to keep you from getting sick. If you have COVID-like symptoms, please see your physician early. You may be a candidate to keep for therapy that will keep you out of the hospital. And these are extraordinarily effective therapies. So with that, I'll pause on the overall and let Dr. Admire talk about the unique situations of Mobile.
Sure. Thank you, Dr. Williamson, Dr. Harris, your comments, and Dr. Aurora. Here in Mobile and Baldwin County, in the last 2 to 3 weeks, we have seen a huge surge in COVID because of most likely the Delta variant. We know that. For example, in Mobile County alone, we have Mobile Infirmary, 669-bed hospital, Spring Hill Hospital, Providence Hospital, and University of South Alabama, and the 5th hospital's USA Women's and Children's. All have had increases. Today at the infirmary, we're at 202 inpatient COVID patients. And out of that, 20 are on ventilators and 25 are on high flow or BiPAP. Our ER is filled to their capacity, and we have ventilators down in the ER waiting for more ventilator beds to be available upstairs. We've expanded our MICU, that's our COVID unit, down the hallway on the one ward, and we can have probably another 20 ventilators if we need. Spring Hill is at over 100. I wrote down here that Spring Hill is somewhere, or they were up to 102. Providence was 105. They're down to 97, which is good. That's a good sign. And if you look across the bay At Thomas Hospital, it's a 170-bed hospital, but they had at one time close to 100 patients, COVID. You're talking anywhere from 35 to 50% of these hospitals having COVID patients of all their inpatient census. North Baldwin's a smaller hospital up in Bay Minette, half of their patients were COVID. So this has put a strain on not only the physician staff, but also on the nursing staff. We're short of nurses. We're trying to find agency nurses to come in and help us take care of these patients 24/7. The EMS service has been overwhelmed by our surge down here. The EMS system has a delay when people call for ambulances. So we're trying to coordinate that better. Dr. Williamson talked about monoclonal. That's our strategy now. What we're doing is the urgent cares and the doctor's offices, if they test and they're positive, and they meet inclusion criteria, which has been broadened, they're now going to 4 different monoclonal infusion sites to receive their infusion to prevent them from being hospitalized. And now not just IV infusion, but we're now giving subcutaneous injection, 4 shots. And that can make it a little more rapid. So we think over the next week or two, if we can get more monoclonals into the residents in this area that are COVID positive, we can decrease our hospitalizations and help out this surge that we have. And because we are at top capacity right now, if it gets worse, we're going to have plans outside of the hospitals where we can take care of the patients possibly. We're not at that point like they are in Mississippi and other states, but if we have more of a surge, this is where we have to start planning.
Yeah, so what I'm hearing now is we obviously want people to go get vaccinated. We're in the midst of a surge right now with hospitals at capacity who've decided to hold off on these procedures that are not elective, medically necessary, but not emergent. And we're asking schools to mask. We're asking people in indoor spaces to mask, because the mitigative measures, the additive mitigative measures are what can help us get through this surge. And then lastly, what Dr. Williamson and Dr. Admire stressed, which is the importance of the monoclonal antibody, because in order for the hospitals not to reach beyond what they can handle, if patients can get this treatment within their 10-day window, then they will decrease the number of patients that are burdening the hospital systems. And so those are the messages that our hospitals and our public health folks are wanting to get across to us as the public, advocating for your own health right now. Dr. Harris, I guess a really tough question to ask in this situation, obviously we don't want to think about this, but just seeing the trajectory and the modeling of where we're headed, that's now going into September. Do we have plans for any federal assistance to help us with these shortages that were just mentioned? Because I imagine the shortages may be the rate limiting step more than the actual hospital beds.
Yeah, so that's a great question. We have had a number of conversations with the feds about doing that. We actually had federal officials who were here yesterday, people connected to FEMA. The Federal Emergency Management Agency. We are talking to them about the possibility of using what are called DMAT teams, DMAT, and the acronym escapes me a little bit, but they're disaster teams that bring in groups of healthcare professionals who can provide staffing. They're teams of about 32 people. You may have seen the story in the news in the state of Louisiana. There are a couple of DMAT teams there. I think there's a third one on the way. So we have requested that the feds evaluate us for what our need is. They have to, make a determination that we qualify and that we need those teams, and of course we do, but I guess there can be other people that may need them more than we do. It's a little bit of a catch-22 in the sense that, there aren't a lot of healthcare professionals sitting around in the United States now with nothing to do. So they've got to come from somewhere, and they are federal assets, but they, I'm sure are people who are working somewhere else now. So there's a lot of that sort of benefit to cost ratio thing that the feds have to calculate for us. But we hope to know something about that very soon. Clearly, we've got staff shortages in our hospitals. Clearly, we'd like to be able to staff infusion centers if we can find people to work in those. And so we hope to have some information on that soon.
And yesterday also were conversations with HHS regarding monoclonal antibodies.
Yeah. We had a terrific call yesterday, and I know Dr. Aurora, you led that call, but we had doctors from all over the state who were, and some others as well, who joined us to talk to specialists from CDC who are also plugged into the Assistant Secretary for Preparedness and Response. That's one of the Health and Human Service Agency offices who oversee America's program for these monoclonal antibodies. So we learned a lot about how they can be used, about new ways in which they can be used, about how they've been approved, not only for people who are sick with COVID, but even people who've been exposed to COVID and hopefully don't have to become sick, because we can prevent it with antibodies. These antibodies are given as infusions, but there's also certain circumstances where you can give them as an injection under the skin as well, which opens up a lot of locations perhaps where we can administer those. So we hope that providers in the state, doctors in the state, understand the importance of doing that, and that they understand how they can access that. And what we're trying to do in public health is try to make those things as widely available as possible.
Dr. Aurora, I wanted to mention, as Dr. Harris said, the DMAT, which is the Disaster Management Assistant Teams, they're in Missouri. They've been deployed in Missouri, Arkansas, Louisiana, Mississippi, and Texas as of today. That was reported to me by Dr. John McMahon, who's head of our DMAT in our region, and that's very important. And remember, there are neighboring states, so we have to be very careful and cautious and watch closely in case we need to do that.
Yeah, especially for your area. I imagine this is something that many of the doctors in your area are very concerned about. Can we talk about the ages of the patients showing up in the hospitals and the severity of disease this time versus last year?
I can say a little bit. I mean, we've looked at the average age of patients, and we've seen it go down from 64 in January to 54 now. We've seen the percentage of patients who are under 35 go from 8 to 9% in January to 16, 17% now. We're now actually also tracking the percentage of school-age children 5 to 18, and that's now about 2.5%. Now, I'm not sure what that number means because it's a small number, but my assumption, and Dr. Admire has the clinical experience, but my assumption was that since these were younger patients, that younger patients had historically done better. But when I started looking at our ICU use, we're on track to use at least as many ICU beds with this surge as we did with the surge in January. So to the extent that ICU bed use is a marker for severity of illness, I'm not seeing anything that says this is a less severe illness. Plus, as Dr. Harris just pointed out, we're now beginning to see the deaths reported that you would expect given the level of hospitalization. And I think one of the challenges is there is a time lag between when people get ill, when they get hospitalized, and then once they're in the hospital, they may be there for 3 weeks or more on the ventilator before they succumb. And then there's a lag from dying to the death certificates being filed and that information getting in the system. So I suspect if you look at the shape of the curve of hospitalization, it's very, very different than what we saw last time. This one is almost straight up. I mean, having a 30% increase in 7-day average hospitalizations in a week when you're dealing with numbers of 1,900 to 2,200 cases, that's a huge increase. So this is almost a straight up curve. I suspect the reason we're just now seeing that spike is because we're just now getting the data from the beginning of the increase. I don't think we're seeing the deaths at this point associated with the peak numbers we're seeing now.
That's a really good point.
I can add that in the last 2 weeks, we have seen younger people die in our ICU, with the youngest being 23-year-old male. Only comorbidity was obesity, a 28-year-old female, a 36-year-old, and then a 52-year-old lady who did not have that number of comorbidities we saw last year in January and before. So this is very interesting with this Delta variant, how they're younger and they're sicker and they get sicker quicker. So this is important for us to know. We've also made some changes in our ICUs where we're keeping the intensive care, critical care doctors 24/7 taking care of our ventilator patients because they need that much intensive care. And that's putting a strain on them. That's a really taxing on these physicians to be with those ventilated patients around the clock in a COVID unit.
Absolutely. Speaking of ventilators, what is the situation on ventilators?
In our hospital, we have 110 at the infirmary, and we're using maybe 60% of those now. So we're good on ventilators. The key is our critical care doctors try to keep the patients off the ventilators as much as possible. That's why they go to high flow oxygen, BiPAP, and CPAP, which gives positive airway pressure, doing those measures and proning the patients and things like that to avoid putting them on a ventilator, which that can cause bad, and the mortality rate goes higher once you go on a ventilator.
Yeah, statewide, we've got over 1,000 ventilators. When I'm thinking about this response, I'm going back to my 3 S's from January: stuff, space, and staff. And in the stuff category were the ventilators, the PPE, and oxygen. And of those, the only one that I have concerns about, and it's really only down in the Mobile area, we're hearing some challenges in oxygen supply because many of the oxygen suppliers in Mobile also provide supplies in the panhandle of Florida. And the one thing, talking to my colleagues on both sides of us now, the bad news is we are about a week to 10 days behind Mississippi, behind Florida, behind Louisiana. So we've probably still got far and away the worst to come. But so I'm not really worried about staff, or I'm not worried about the stuff. Space, we can convert non-ICU spaces into ICU spaces. You've already heard Dr. Admire talk about how they're holding patients and treating patients in the ER as though those were ICU spaces. We've got, in Baldwin County, they've got more ICU patients than they have ICU beds. It's true in Dothan. So we can expand the space. The rate limiting step in our response is going to be staff. And that's really the thing that makes me most anxious about how we're going to get through this.
Yeah, that is absolutely true. Patients who are coming in for the heart attack, stroke evaluations that are having to wait for longer periods than they have ever waited before, I don't think they've ever realized that this could be the case. I think people just assume that in the medical system you have the places and the treatments that are available for non-COVID related conditions and then everything else. And we are now at a point where this is just not the case. And I think it's really important to convey that to everybody who lives in our state right now.
Yeah, I sort of liken this to a bathtub. The hospitals were, 3/4 full before COVID. And that was in large measure because of catch-up. I mean, Dr. Admire can speak to it specifically, but our hospitals were seeing a lot of very sick patients who had deferred and delayed care because of the first surge. Well, they didn't go away, and now we're adding COVID on top, and we're admitting more COVID patients every day than we're discharging. I mean, today we admitted another 499 to be precise, new COVID patients. So, we didn't discharge 499 COVID patients today. That means probably tomorrow's number is going to once again be higher than today's number. And so we're just slowly, not too slowly now, unfortunately, we're slowly filling this up, and we're going to end up running out of capacity unless we really get a lot of help out of mask wearing and especially the monoclonals.
Absolutely. I think, Dr. Admire, were you saying something?
Yeah, I was going to mention that was a great point by Dr. Williamson talking about the operating rooms. People need to understand that there's emergent surgery, urgent surgery, and then there's elective surgery. We have limited our elective surgeries, cut them out at some of the hospitals totally, and just go with urgent and emergent. But elective surgery is outpatient. They can come in and get it done and go home. try to keep that going, but we're not at that point now because we need the nurses up on the floor. So once again, we're going to put people back, scheduling their surgeries down the line, 3-4 weeks, whatever it takes to get over this. And that hurts the overall healthcare of the community. Like before, we were trying to play catch up. Now we're going to have to do it again. The other thing I wanted to mention was when you bring in DMAT teams to areas, the disaster management assistant teams, the feds bring in all the supplies and things that you need, and then they look for people to staff. And you don't want them to hire your nurses because we don't have enough nurses now. That even creates more of a problem sometimes. So that's when you have to get outside nurses to come in. It's a huge problem, but they do wonderful things. You need DMAT teams, and they're excellently trained, but it does logistically, it hurts operations sometimes as far as staffing. And the hospitals, we don't have any nurses to spare. Our hospital, just to say, Dr. Aurora, last year at our peak, we had our 4th floor of our hospital. We just made it into a total COVID unit, and I think our peak was 135 patients. We're already at 202, so we've taken our 5th floor and made half of our 5th floor plus our 4th floor all COVID. And then you have nurses that only, because we don't want the nurses going from COVID to non-COVID, so then you designate your staff just to be with COVID patients, your other non-COVID nursing staff. These are hard problems when you're short. And so, but one thing good about the Mobile area in Baldwin County, the hospitals know we're all in the same boat. The nurses are staying put at the hospitals they're at. They're not going to different places. We all realize we're in this together, and that's a great way to be as a team. And that's the same way with the CMOs meeting once a week along with the Board of Health. That's a very good thing. And we also participate in the press conferences. We go on the local TV channels when asked to talk to the citizens and give them the message.
You hit on some really good points. I don't think we can do this without that community feeling. Hospitals are doing this statewide. Anybody involved in the medical communities are all collaborating together right now. We're collaborating with elected officials within our cities to get messages out with our mayors. So all we are asking right now of the public is for the same community kind of feeling. If we can come together right now, this is our ask. Hospitals, doctors, nurses, your community, elected officials, school systems, we all want to continue to lead our lives and not have a state of emergency where we are shut down. But if the honest truth be told, if we continue on this trajectory, whether we call it a shutdown, by definition, we will be shutting down. Any further thoughts?
I think if I could say one more thing about getting a public message to everyone that's not vaccinated and doing it in such a respectful way. I think it is a personal choice whether you get a vaccination or not, but you must have an informed decision when you make it. And I think if people know the facts, the science behind vaccinations, how they work, how safe they are, how efficient and the efficacy of them, how they actually prevent people from contacting disease, they lower the symptoms if you do contact it, and they decrease hospitalizations and mortality. It's proven. Worldwide, we've given over 4 billion shots of vaccinations worldwide. In the United States, we've given close to 350 million. We have 50% of our adult population vaccinated right now, but we need to get 90 million more adults vaccinated to maybe make some type of, to use that word, herd immunity, if that's possible. That's where it may be even higher now because of the Delta variant. This is important. Dr. Francis Collins from NIH came out the other day and quoted that if you're vaccinated, you have 3 times the chance to contact COVID-19. You have 8 times a chance that you will have symptoms, and 25 times more likely to get hospitalized. Those are what the community needs to know, and know that how safe it is. There's only been a few things, and Dr. Williamson, you probably can comment on the side effects are minor, but they've reported some things such as Guillain-Barré or thrombosis or thrombocytopenia and anaphylaxis it's very rare with 4.2 billion shots worldwide. So that benefits way outweigh the risk.
You know, I would just pick up on that point. One of the things that we constantly run into in terms of getting people vaccinated, and I know Dr. Harris does, is this perception that somehow the vaccine was rushed. It didn't go through all the safety protocols. You know, the reality is the messenger RNA technology was not new technology. It was just an opportunity to use that technology to expedite vaccine development. The next thing you've got to have to get a vaccine approved, you've got to be able to prove it's efficacious and effective. We had, I guess it's an advantage, but we had the opportunity to do the studies when the virus was circulating readily. So it was very easy to very quickly identify that the vaccine was protective, because people in the placebo arm and people in the control arm were both getting exposed very easily. And then the safety profile, I mean, you pointed out there may not be another vaccine in history that we've given 4 billion doses of. So, you know, if you just look at it, there's nothing surprising about the safety profile. You know, people aren't losing fertility. They're not dropping dead from this vaccine. Have there been a few anaphylactic reactions? Yes, very small and almost all well controlled. The side effects are for most people a sore arm, and after the second dose, maybe a sore arm and some flu-like symptoms, but they are absolutely better than dealing with a ventilator. I'm sorry. Wearing a mask, for example, is a whole lot easier than having an endotracheal tube in your mouth. So, you know, all I can suggest is, number one, back to your point, if you're on the fence about getting vaccinated, please talk to a healthcare professional. Don't get your information off the internet. Talk to a healthcare professional. They'll give you their best medical advice. And getting vaccinated, you know, get vaccinated for yourself. Dr. Harris released some numbers today. We've been working with the hospitals to get vaccination status of people in the hospital. And we've done this now over the last 4 days, and it's been very consistent. 11 to 12% of the people in hospital are vaccinated. The other 88% are either unvaccinated or partially vaccinated, and only about 3% of that is partially vaccinated. So the overwhelming majority of people in the hospital with COVID are unvaccinated. The people who are dying are, 99%, Dr. Harris, are unvaccinated. So, you know, number one, get vaccinated to protect yourself. But the other half of that is we've got children at 12 years of age, under 12, who can't be vaccinated. Vaccinating parents, older siblings, and other people in their circle of contact, the only way to protect them from getting infected is for them to wear a mask and for you to be vaccinated. So if you're not going to be vaccinated for yourself, be vaccinated for your children, your grandchildren, and other younger people that you care about.
I think that's a very powerful message, especially the children under 12 who are not able to get their vaccines, and scary as we're hearing from places that are starting to have children in the ICUs. This is a different situation. The Delta is doing different things than it did last year.
Dr. Aurora, if I would just, you know, want to say how I agree wholeheartedly with Dr. Admire and Dr. Williamson, and just put a little bit finer point on it in a way. As Dr. Williamson just mentioned, virtually all the deaths we're seeing are among unvaccinated people. This vaccine protects very well against infection, but it protects even better against dying if you are infected. And so the message we need people to understand is these deaths we're seeing now, 3 dozen yesterday, almost 4 dozen the day before, these are preventable. These do not have to happen. Every one of those, almost every one of those deaths would not have happened if these were folks who had been able to get vaccinated. Now, again, some people don't have a choice. You know, kids under 12 don't have a choice about getting vaccinated. We have a lot of Alabamians whom the vaccines just don't work very well in. You know, they're people who maybe they're on dialysis and sometimes they don't respond as well. Maybe they've got a transplanted organ, you know, they're on immunosuppressive medicines and the vaccines just don't work for those people. Please get vaccinated, because it does help other people. It's something that you do for other people around you. You know, I have been vaccinated, and my wife and my parents have been vaccinated, my kids, all of our grandkids who are old enough. We have done that because we think it's the right thing to do, and it's how we keep ourselves safe, but it's also how we get our family back to normal. And we feel like we're doing everything we can to try to return to the way we are. But the one last point I'll make is just to reiterate what Dr. Williamson said. In the next couple of weeks, at least the Pfizer vaccine is going to have full approval by the FDA. It may be 2 or 3 weeks. It may be 4 or 5 weeks. It's going to happen immediately, almost immediately. We are going to have more safety data about this vaccine than any vaccine ever in the whole history of vaccines. There's never been a vaccine that was given to 190 million people before it even was approved. And the reason they do that is that all the safety data indicates it will be fully approved because it's a safe vaccine. The risk of dying from COVID are about 1 in 50. You know, we're getting 4,000 new cases a day. About 1 out of 50 are not going to survive that. We know that. The risk of dying from the vaccine are essentially zero.
Well, I really appreciate the three of you sharing these messages. The take-home points being vaccinate, wear your mask, even if you do get vaccinated, because we are in the midst of a vertical surge where we just discussed hospital situations throughout our state and the possible need to have federal assistance, which we would not really want. And then lastly, if you do get COVID, make sure to know that the monoclonal antibody is something that you need to ask your doctor about. And that treatment is available to you, but the time starts ticking. Once you start having symptoms, you really need to go get tested so that you don't waste any time to get within that 10-day window to get your monoclonal infusion.
I wanted to say it's interesting that we've almost become a pandemic of the unvaccinated. And at the same time, now people are talking that people that have had the vaccine, the 2 shots, or the 1 shot with the J&J, the Johnson & Johnson, they want to get boosters. So they're now looking in, the health officials are looking into when are people going to be eligible for boosters. And I thought that would be a good point to talk about. Dr. Aurora? Yeah,
Dr. Harris, do you want to talk about that? I know there is some discussion about the boosters coming out for immunocompromised.
Sure. So the news stories we're reporting today that CDC is going to announce tonight or tomorrow guidance about boosters of people that are immunosuppressed and have immune system problems who don't respond normally to vaccines. I don't think anyone's surprised by that guidance. We know that people who are immunosuppressed don't respond well to most vaccines or maybe any vaccines. And so a lot of times they do need additional doses or higher doses. So we certainly think that is exactly what we would expect. I don't know how soon, but very soon, I think we're going to see the same guidance just about people who are seniors, people over 65 as a group in general, not in all cases, but in general, don't mount as robust or immune response to vaccination as well. And that's why, you know, for a flu vaccine for seniors, and, you know, for example, sometimes seniors just need a little bit extra. So I think we're going to be hearing about that soon. I don't know that that'll be part of the announcement today or tomorrow, but it'll be very soon. I think most people probably agree, though, we're probably all going to get boosters at some point. This is probably not a vaccine that's, you know, going to give you lifetime immunity after your first round. It may well be that it turns out like the flu shot, where you need to have something a little different every year. You know, it may be a little bit longer than that, or it could be sooner. But boosters are definitely coming. We've just been waiting to get guidance as more and more evidence accumulates about the best way to do that.
I think the important point still there is that if you were vaccinated in June, you are still covered. You're robustly covered. And the only way out of this, it's not to say that, oh, well, why do I need to get vaccinated? It looks like people are going to have to get their 3rd vaccine. It's really the only way forward for us to prevent this virus from mutating and becoming smarter and coming at us again and making our vaccines less efficient is for us to get more people vaccinated. So again, the message is to vaccinate, to wear your mask indoors, and to remember the monoclonal antibodies. Thank you, everybody, for your time. Oh, Dr. Admire, did you have something to say? Yeah.
I did. You made me think of one more thing I think is so important. Sure. for anyone listening, and especially the physicians that have patients, I think it's our opportunity as doctors, and what we do, Hippocratic Oath, do no harm, take care of people. The message you give must be given in a wonderful tone to the patients, even the ones that say, I don't want it, I don't believe in it, because they read something on the internet, like Dr. Williamson mentioned, Dr. Harris. But if you sit down and talk to them, have a good tone, respect them, and listen to what they say, and then you explain to them the facts, the data, the evidence-based medicine, and then tell them, say, listen, many, many years ago, decades ago, there was smallpox in the world, and it was a deadly disease. We eradicated that from the earth, from the planet, by vaccination. And everyone did it because you just did it because your mother took you to the doctor and you got a smallpox vaccination. I still have it on my arm. And then we did the same with polio, how we get polio vaccines. Here we are in 2021, 2020, with coronavirus, which is turning out to be across the world causing many deaths. 4.5 million people have died, and hopefully not more. So it's the way you talk and give that great message as a physician. I think we can persuade enough people that don't quite trust it or believe in it to understand it and then get it. We can make a change and get that immunity that we need amongst the population.
Dr. Admire, I really appreciate that message, because you're right. As things get more trying, we have to remain true to the compassion that we have for others. And if we let go of the compassion, we are losing. And so therefore, treating everybody and giving them the information and not putting blame on anybody. Just, we've all got to really go forward with the compassion for each other. And I think that you hit the best message of all at the very end. Thank you for that.
Thank you.
Dr. Williamson, do you have anything else?
No, I would just, I would echo that. I mean, the reality is it's a new vaccine, and people having questions about it. It's, if you don't live with this every day, I fully understand the reason to have questions. I would want to pick, though, up, Dr. Aurora, on your point about why it's so important that we get to herd immunity, whatever that is. And it's maybe 90% because of the R naught of this, the infectiousness of this virus. Life finds a way to survive. And so if we don't eliminate the ability of this virus to replicate, we will get mutations that favor a new strain, a new variant of the virus. And then that variant, if it has a selective advantage, will end up becoming the dominant variant. And I think the thing that scares me, and I think most of the people who are thinking about this, is that the variant that we get could render our vaccine ineffective. And then that doesn't just put the people who have chosen not to be vaccinated at risk, or who can't be vaccinated. It puts everybody at risk. And we could, in essence, be starting all over again as though we had no vaccine. So, I mean, it's important, even as we get this surge under control, and we will get this surge under control. We'll either get it under control because we got enough people vaccinated, or we'll get it under control because we'll get to herd immunity because it burns through the entire susceptible population. Well, if we get it that way, we're going to have a lot more viral replication. We're going to have more variants emerge, and we're going to have a lot more hospitalizations and preventable deaths. So it's just important for us to the extent that we can to encourage people to please think about getting vaccinated. It's critically important, not just for you, but for everybody.
Absolutely. Some really wonderful messages here. I really appreciate all three of you, Drs. Admire, Drs. Williamson, and Dr. Harris. And public, please do go get vaccinated. Thank you.